count to 10 for me, please.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay.
2, 4, 6, 8, 10.
Mr. Holloman.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay, very good.
Hey there, ice cold milk and an Oreo cookie. They forever go together like a classic combination.
Mic check. Ooh, okay. Mic check 1, 2, 3, 4, 5.
Good afternoon, everyone. I'm WFMY News 2's Tanya Rivera, and we just want to say thank you very much for coming out to our town hall here in person, and for all of you who are watching on Facebook Live as we stream this entire town hall live on Facebook and on YouTube as well, and on WFMYnews2.com. This opioid town hall is in conjunction with the North Carolina Attorney General's office. And before we get started, I want to make sure that everyone has at least one of these index cards in their hands. If you don't have one, I want you to be able to raise your hand so that we can pass them out to you. This is how these index cards play in. This is your way to be able to talk to the panelists here and ask your questions or have your comments heard and have them respond to them. On each one of these index cards is a sticker on the top, and it says my question or my comment is about, and there's different categories of what we're talking about today: the problem, prevention, treatment, and enforcement. We want to make sure that you get your question or comment in each individual category heard and answered. So we want to make sure that you actually write this down. If you need a couple of them during the entire town hall, not a problem. All you have to do is raise your hand again. We'll be by again with the index cards. For those of you who are watching live on YouTube or on Facebook or on WFMYnews2.com, all you have to do is talk to us through Facebook, and we'll be able to get your questions as well to the panelists. You don't have to include your name on these index cards. You certainly can if you want to. We definitely want today to be a conversation. We want it to be a discussion. We want it to be an exchange of ideas. We have a panel of experts here on the stage, but we also have special guests with us in this front row that have varying connections to the opioid epidemic, and so we want to be able to hear from them as well, and you'll be able to ask some comments and questions from them. We want to hear from you no matter where you are. So again, if you are watching this now on Facebook Live, we want you to be able to give your questions and your comments so that the panel can then answer them. Let me explain how this town hall is going to go so that you know what kind of order we're looking at. So first and foremost, we're going to kind of go through our different discussion points, and then we'll also get you to meet each one of the panelists. We're dividing the conversation again into 5 different categories. So we have the problem, we have prevention, we have treatment or recovery, we have enforcement, and then our last bit is going to be taken up with what's next? What do we do from now on? In our first 4 sections, we're going to have a short video and a presentation on each segment so that we can all be just a little bit more informed on each one of these topics. It might even answer a question that you have, or it might spur you to answer another question. Each segment that we're going to do on each one of these topics is 30 minutes long. Could we do 2 days on every topic? Absolutely, we could. But we need to keep it to 30 minutes so that we will be able to get all of the questions and comments for each one of these sections in. We'll have some questions for the panel after that video, and then it'll be followed by questions from you here in the audience live at the town hall and those of you who are on Facebook Live. We want to give plenty of time for each section and for really good conversation. But again, we have 30 minutes. So this is how we're going to make sure that we stay on time. You see this young lady right here? There she is with her hand up. She has a red card and a yellow card. That yellow card is, hey, time is getting short. We need you to kind of wrap up what you're saying. The red card means we got to move on. Okay, and so that is for the panelists, and that is for any of the people who are answering the questions in the front row or asking questions as well. We want to make sure that we are able to hear everything that you want to hear about and talk about today. So at certain points, you'll notice those sheets of paper. Make sure that you are paying attention. If not, I might be able to have to say, hey, we got a red card here. So let's see if we can move this along. We're going to continue on that pattern of the video, and then also the talking points, the panelists, and then the questions for each one of those segments. All right, so let's take a minute now to introduce our panel to you. And so what we're going to do is, starting from my left side here, if each one of you will just say your name and your title and just a brief snippet of why you're here.
Thank you for having me. My name is Bobby Kimbrough. I work in the Office of the Sheriff in Forsyth County. I've spent 35 years in law enforcement. I just recently retired as a special agent with DEA in 2016. And I'm here because I feel that it's much needed, and I too have suffered the loss of someone from an opioid overdose.
I am Elizabeth Schilling. I'm an assistant professor at Wake Forest School of Medicine and Wake Forest Baptist Health. I am here today because I am trained as a clinical addiction specialist and provide those services and supervise counselors and clinical addiction specialists and peer support specialists at Baptist Health, providing services to individuals who suffer from substance use disorders.
And North Carolina AG Josh Stein is here. He is on state business. Hey there, I see it. He's getting mic'd up, and he'll be heading to the podium in just a moment.
I'm Susan Stevens. I'm the mother of both Jorian Stevens and Toria, who I lost in January of 2018. And I founded Teal Drops in her memory, and that is for a global end to opioid misuse and prevention. I am also one of the newest students at Wake Forest for the Addiction Research Master's Program. And I'm here really to address parents and loved ones that lose someone, and the guilt and the stigma and the shame that we all feel, and just some of the healing things that have helped me, and that if I could help others.
So my name is Chase Holloman. I'm a clinical social worker and clinical addiction specialist. I'm also a former IV drug user, a person who has overdosed several times, which is what brought me to this profession. I work for Guilford County Solution to the Opioid Problem. We're a partnership between Guilford County and University of North Carolina at Greensboro. We support people at risk for overdose, our primary goal being reducing overdose death by 20% in Guilford County. And that's why I'm here, is I'm tired of burying my friends and my loved ones. And I want to see people live and find recovery and enjoy life. So that's why I'm here.
All right, so you've heard from our panel, really diverse, well scripted in this of what is happening in our state, what is happening in our own homes and in our communities. And so as we get this started with the discussion, we're going to begin with a look at the problem. And WFMY News 2's Maddie Gardner has the story from here.
A photo can capture how a person looks.
I think of a happy, smiling, fun-loving guy.
Even a moment in time.
I just think of, my brother and growing up together in childhood and memories and all of those things.
But it doesn't show the internal battle.
You see this person and you think it's your loved one, and unfortunately, they have, the drug has completely taken them over.
Of a person battling an opioid addiction. Zach Ayer's addiction started when he was a teenager.
His dad had back problems and had
A
pain
Vicodin
pills,
prescription.
hydrocodone, and Zachary took a whole bunch of them from him.
That led him to heroin because heroin was cheaper than getting these pain pills that he was using.
On July 9th, 2017, a family member found Zach's body.
He thought he was buying heroin, and there was no heroin in whatever he used.
Every day, nearly 5 North Carolinians die from a medication or drug overdose. In 2017, that was nearly 2,000 people. And behind every statistic, a face, a family, a mom.
It's just the worst thing ever. And now I do not have my child.
It is unfortunately a story that we have all heard too many times. So with more on the problem, please welcome Steve Mange, Senior Policy and Strategy Counsel from the North Carolina Department of Justice.
Thank you so much, and thank you all for being here today to discuss this very difficult and sobering topic. When we talk about the opioid epidemic, if I could have the first slide, we're talking about a problem that has killed 400,000 people in the United States over the last 20 years, including, I'm sure, many people known to you all who are here today in the audience. The problem is so grave that it has actually put the brakes on a century of progress in life expectancy in the United States. So for 3 years in a row now, because of the opioid epidemic, life expectancy in the US has actually declined. The first time that has happened since the flu pandemic of 1918. And so that is the seriousness of the problem that we're here to talk about today. If I could have the next slide. As many of you know, the opioid epidemic is really 3 epidemics. It's a 3-wave epidemic. The first epidemic that started in the 1990s was brought about by the overprescribing of prescription painkillers, pushed very heavily by Purdue Pharma and other drug makers. The second wave started around 2010 when Mexican drug cartels were able to produce and import cheaper and cheaper heroin. It was a classic supply and demand story. The supply of cheap heroin was there, and the demand was there because so many people had become addicted to prescription painkillers. And as you know, chemically, prescription painkillers and heroin are essentially interchangeable. And then the third wave of the epidemic started around 2013 with fentanyl, a drug that is incredibly cheap to make, and it is made in illicit laboratories in China and shipped to the Mexican drug cartels and directly to the United States. It's a drug that's even cheaper than heroin, and it is deadly. And so if you look at the next slide, this 3-wave epidemic is easy to see right here in North Carolina. So if you look at the green part of the slide, that is the rapid rise of overdose deaths attributable to prescription opioids starting around 1999. Then when you hit 2010, you see the dark blue area. That is fentanyl, that is heroin and fentanyl overdose deaths. These started to spike around 2010, and then you can see this dramatic and tragic rise in overdose deaths due to fentanyl and heroin since 2013. If I could have the next slide. You've already heard the numbers for North Carolina. The impact of this 3-wave epidemic has been devastating, both in terms of the numbers and in terms of the individual lives affected. Over 2,000 opioid overdose deaths in 2017. That's more than 30 deaths a week, more than 5 deaths a day on average. And the next slide, please. And what we know about these deaths is they're just the tip of the iceberg. that when we talk about an overdose death, that also corresponds to 2 or more hospitalizations, 4 or more emergency department visits brought about by an opioid overdose, 200 residents misusing prescription painkillers, and nearly 4,000 opioid prescriptions dispensed for every single opioid overdose deaths. Next slide, please. And you all know that the triad has not been spared in this epidemic, that in Guilford County alone in 2017, there were 93 unintentional opioid overdose deaths in 2017, 461 overdose emergency department visits, and over 20 million opioid pills dispensed. Next slide, please. In Forsyth County, 71 unintentional opioid overdose deaths, 247 opioid overdose emergency department visits, over 16 million opioid pills distributed. And of course, I could give you these statistics for every county in the triad, and every county that surrounds the triad, whether it's an urban county, a suburban area, or a rural area. Opioids just don't care where you live and who you are. The final slide, please. And one last thought that I leave you with as we think about the impact. Of course, the human impact is incalculable. The impact on individuals and families torn apart by addiction and overdose and death. But there's another impact as well, and that is the social impact, the economic impact. And that can be measured many ways in terms of the impact on the healthcare system, on the criminal justice system, on the social service system, and perhaps least understood of all, the huge impact on the economy as a whole in terms of lost productivity due to folks who have become addicted or folks who have died from opioid overdoses. And so, although there's many ways to estimate the economic impact, I leave you with one number. The economic cost of the opioid epidemic, according to the White House Council of Economic Advisors, exceeded $500 billion in 2015 alone. Thank you very much.
All right, so let's get the conversation started with our panelists here about what we have been talking about problem-wise. I think a lot of people would question, what does opioid abuse look like? What does the usage look like? And I know that at least 3 of you have specific stories to tell of what did it look like in your homes with your loved ones. And so, Sheriff Kimbrough, would you like to tackle that?
Sure. When you say what does opioid addiction look like, it has many different faces. You know, every day someone is addicted to an opioid. They could be black, white, doesn't matter. Opioid addiction is very indiscriminate. It doesn't respect race, color, creed, economics. What I would tell you what it looked like to me was, I didn't know what it was until my wife passed. I would tell you that opioid addiction in America, we have to change how we look at addictions, because how we look at addiction is how we apply our resources. We approach addiction that that's somebody else's problem, and the truth of the matter is all of our problems. You know, you heard me say this many times, it's not a political thing, it's black, white, it's a life and death thing, because it will affect someone that you know eventually, if it has not. So it looks like many different things to many different people. But
and it was a surprise look to you.
Without question. And I say it was a surprise to me because here I was at the time, I was a special agent with the DEA, had spent time in Detroit and fighting the so-called drug war, but not knowing what was actually happening in my own household. Because a lot of times, those persons that are addicted to an opioid, they're functional. Every opioid addictor is not someone that you see sitting up under a tree or something. There are people that are functioning addicts, and you will never know that until something happens. And that was pretty much my case. Toward the end, about a week before, I noticed something. But what I would tell you is that the common denominator is eventually death.
How about you, Susan?
Unlike Bobby, my daughter, I absolutely knew. And in some ways, I was blessed to live through her addiction with her. She was sexually assaulted August 7th, 2014. So there was a 3.5-year window from the rape to the death. And during that time, I was there for the rape kit, and I kissed her goodbye naked on her bedroom floor 3.5 years later. What people don't understand is that's my child in the picture there, and I have her bucket list here. My daughter was a superstar. She was gifted academically. She did everything every child did. She was on all these sporting teams, cheerleader. She was in the student leadership, appointed by the mayor. She went to DC to student leadership conferences. She was an amazing kid. I was prescribed opioids for my back and neck. I broke both of them in a car accident in multiple places. And the first pill that she ever put in her body came from me, unknowingly. And most every child or adult that ever uses an opioid will get their very first one out of the medicine cabinet. That's the first thing we need to be aware of, is the medicine cabinet. The second thing I want to address is the norm. We think of a norm as how we're sitting here today. Okay, this is just our average, this is our norm, this is how we feel. For someone who is addicted to opioids, the norm starts 20 below. They wake up in the morning and they have to use heroin or Vicodin or whatever opioid that they can get a hold of to bring them to a level of functioning. And that's hard to understand or comprehend, but just to get out of bed or to even be able to drive a car. Now, you say, well, they take heroin to be able to drive a car. I am here to tell you, they can't drive a car in that withdrawal phase without it. It gets them to the level. If they use more, they go above it. But just to be a normal functioning person, when they're in deep addiction, they have to have that. And my daughter went from this beautiful child you see in the picture, thinking of herself as a beautiful princess in her childhood, to hating herself and be ashamed and the guilt. And I have a lot of shame and guilt too for a lot of things, and we'll discuss that later, but it changes not only their look, but they have the shame, and they don't look pretty anymore. They don't have that glow that they once had, and it's horrible. It affects everyone around them, not just them. And so we live, those of us that have a loved one active in addiction, it is so much harder than to know they're at peace in heaven. That is to watch someone you love is the hardest thing.
Chase, I was wondering, since we've heard two different kinds of stories of the problem, if we've been talking about how opioid epidemic has grown over the past few years. You've been on both sides of it. What do you think is responsible for that?
I think what we're seeing specifically is an overdose crisis. I don't know that drug trends change that often. They go up and down. But what we saw was the advent of fentanyl into the illicit drug supply. And what this did was cause a large spike in overdoses, similar to what we saw with opioid painkillers. And that is what is causing a lot of attention, is this immediate threat to life as people are overdosing and dying. We didn't see that before. Specifically in my own drug use, I overdosed quite a few times, and it was due to me mixing drugs, not specifically to just doing heroin or fentanyl, because fentanyl was not introduced to the drug supply yet. So people that are using drugs today are using in a much different environment than people did before. And I think it's important while we're having this conversation to remember that not everyone who uses drugs or not everyone who uses opioids is addicted or lives with problematic substance use or chaotic substance use. What we see in the media mostly, what my story was, are people that are stuck in chaotic use, people that maybe have the allergy, right? So when I take an opioid or when I take any mind or mood altering substance, what happens is my brain gets hijacked, and when I start, I cannot stop. No matter how bad I want to, no matter what consequences are put in front of me, I cannot stop. So it's important while having this conversation to remember that. So I think that it has grown, but specifically just overdose deaths has grown in a dramatic way because of the advent of fentanyl.
Right, I have two more questions for the panel before we go to the audience. And so the first one I'd like to direct to Dr. Schilling. What does it mean for our communities? And then I'll ask the AG, what does it mean for North Carolina as a whole, big picture?
Well, for our communities, it means a tremendous number of individuals and families affected by, I think, what Susan was talking about, that devastation, and a really huge crisis that goes along with that, in that we don't have enough treatment opportunities for individuals who face addiction of any kind, and opioid use disorder specifically. And so for communities, it's, I think being in North Carolina and Forsyth and Guilford County, we can especially attest to, we have rural communities in these counties and our surrounding counties, and rural communities are really affected by opioid use disorder and addiction, and have very few resources to support those families and individuals, and that, I think, just really tremendously impacts that crisis and has caused it to stay in such this sort of stagnant place without a lot of progress.
Tanya, thank you. Pleasure to be with you all, and I really want to thank FMY for hosting this town hall. It's an incredibly important topic. Basically, the statewide impact is the aggregation of tens of thousands of stories like the three that we just heard. There are three stories, and you're like, okay, that's a problem. But there are literally tens of thousands of people struggling with opioid use disorder in this state. And it's an incredibly deadly epidemic because of, as Chase noted, the introduction of fentanyl, such that it is the deadliest drug epidemic our nation's ever faced. Steve noted that the United States is the only industrialized nation in the world with a declining life expectancy. 3 years in a row, the life expectancy is declined in the United States. First time in 100 years, World War I and the influenza epidemic. First time, only since that time. And a 15-year-old male in the United States has a lower chance of reaching 50 than a 15-year-old male in Bangladesh. This is the United States, the wealthiest country in the world. It's devastating individual lives, it's devastating systems. Our criminal justice system, I'm sure the sheriff can tell you what percentage of his inmates have either substance use or mental health challenges. I bet you it's 3/4, 80%. Our state prisons are filled with people with addiction. Our healthcare system's inundated. EMS is constantly having to make calls to try to keep people alive who have overdosed. Our emergency departments are the gateway for people with overdoses. Our NICUs are at a cost of about $4,000 a day, having to deal with an increasing number of babies born with dependence on opioids. I was in the Wake County NICU, and of the 36 babies that were there that day, 8 had opioid dependence. And they're there for an average of 19 or 20 days. That's $80,000 a baby, just so they can start life at the zero line instead of starting with addiction. Our foster care rates are going through the roof, and there's incredible cost to the social services and just cost to children. The trauma of not being raised by your own parent is impactful and makes a difference on that child's long-term life's prospects. So the impact statewide is devastating.
Family-wise and also resources-wise on city, county, state levels, right? Okay. We're going to now turn it over to the audience questions. Again, if you are watching this live town hall on Facebook or on YouTube, the way that you submit questions is through Facebook so that we can ask your questions. But we have audience members here who have asked questions as well. We're going to throw this to Tahisha to see what kind of questions we have.
Sure, and I do just want to remind you, if you in the room do have questions, raise your hand with your card so that I can walk to you periodically throughout this evening. So I know we mentioned a little bit about what does it look like, but are there any signs or symptoms? This person wrote here, the construction industry is the most susceptible for opioid abuse. Most workers are subcontractors to the builder. How does a builder recognize anyone on a subcontract that may be using or abusing? Is there some way that they may look?
And that's really rough, because I know you just talked about how you were living with someone and did not know. So what can we tell people?
I mean, when you say, is there things to look for, I think that each individual carries the addiction differently based on the body makeup and a lot of things. My wife was an RN. I mean, she was the charge nurse at one of the major facilities in this area. So to say, what does it look like? Are there any signs? I'm sure you see signs toward the end, the latter part, but the beginning signs, I can't say that you see the signs.
They hide it very well.
Oh, very well.
And they still operate regular. They drive kids to school. They make meals.
I just think that my mind has been spinning since we had this conversation opened. It's been hard for me to get on track, because when we talk about this opioid epidemic, we got to really understand how we got here. Where did it begin at? This opioid epidemic didn't start last year. If you go back to 1995, 96, when me and the chief was fighting cocaine drug dealers in the urban areas, we as an American society had a totally different look on what drugs were, because it didn't affect us. In 1973, President Nixon declared war on drugs. We lost more soldiers in the Vietnam War than matter of fact, we've lost more people last year in 2017 than they lost in the Vietnam War. What I'm saying is that we've got to realize how this began, where we are now, and how did we get here. And every year the numbers are increasing, and they're increasing because the way we approach it. This is not something that I'm looking for somebody to lock up. We can't lock this problem up. This is not a problem we can arrest our way out of. This is a problem that's going to require all hands on deck. It's not a problem that looks like somebody that doesn't look like me, somebody that can't function. This addiction, without question, according to the CDC, is the worst epidemic that we've ever had on American soil, bottom line. So there's no one size that fits all. If you're looking for that, I don't know where that's at. I know that it's going to require everybody, whether you are a social worker, mental health, whether you are a soccer mom, it does not matter. It's going to require educating people.
Educating those who might feel like, I just need to take this to feel better here and there, and no, I won't get addicted kind of thing. Educating the other people in your home to have discussions.
I'm saying educating as young as our middle schools. We had overdose in our middle schools a couple years ago in the county that I'm out of. So when I say educating, I'm talking about educating all the way down to our elementary level, because you have drugs in middle schools.
Right.
You have addictions, opioids in middle schools. So this education that we're talking about has to be an education that starts as early as elementary, because by the time a young adult gets to high school and has an addiction, you're fighting an uphill battle. I've talked to men and women who are addicted to opioids. I've heard men say it's the best thing I've ever had in my life. Don't understand it, but that's what they say. What I'm saying is that we've got to start as young as our elementary. It has to be something that we involve education, awareness, because if we don't get a hold of it, and as the gentleman, the doctor, was talking about the numbers, if you look at the numbers, they're jumping in 10,000s every year. 2017, it was over 70,000. 2016, it was 60,000. 18, they're talking about 80,000. So if you look at 10,000 increases every year, I mean, this should be priority number one. And the numbers and the young men that are dying are getting younger and younger. Every day I get a cold white and overdose in Forsyth County, my heart skips a beat, because I don't know if that person is going to make it or not. And I realize the seriousness of it, the availability of it, the drugs, the problems. And we used to talk about the trickle-down effect. It's very difficult for me to sit here and be composed, because this does not affect our society from a pharmaceutical. It affects our society from the violence. It affects our society from home breakings. It affects our society from car breakings. It affects our society from purse snatching. It affects our society from prostitution. It affects our society from every aspect of our society that you can think of. An addiction will affect it. Even the merchants at the mall. Me and the chief was talking about things that are happening at stores where people are running in just high and just snatching grabs and craziness. So this is very serious, and I applaud you, as the AG said, for taking this by the horn and addressing it. The audience should be packed, but I appreciate you, not to take up the time. I'm sorry.
Oh, no, we want you to answer the questions just that way, so thank you very much. I wasn't sure if we had another audience question.
We're getting more towards, I guess, our later topics in terms
okay.
of prevention, treatment, and enforcement. There was just one comment I did want to make. Someone in the audience sent me this. I'm tired of being treated like a criminal. Why are you letting this affect the people who are legitimately needing pain medication? Because we talk about the opioid epidemic, and there are people who do need these medications to live.
Right, and I know Chase talked about that just a little bit as well, and Susan?
I am a chronic pain sufferer. I broke my back in 2 places, my neck in 2 places. I crushed my hips. I was born with a club foot, and I've had knee surgery on the opposite leg. I am a chronic pain sufferer from head to toe, from morning till night. I wake up and I go to sleep in pain. When I was prescribed opioids, it started with Vicodin in 2005 at my car accident, 1 a day, and it slowly progressed to 3 Percocet a day, 10 milligram apiece. The pain that the Percocet were causing were actually what the real pain was being caused by the wearing off of the opiate. And I would not have ever believed that myself if I hadn't lived through it. And the only reason I quit taking my prescribed medicine that I didn't even take the max of, I actually would break them in half and take less than prescribed. But the only reason was because I saw my daughter for the last time, November 24th, 2017, her birthday. And on December 7th, it just in my gut for weeks, and from that day, it just impacted me to see how awful this child looked. And I couldn't deal with it, and I quit taking my own medicine cold turkey on December 7th. I never saw her again alive, but I didn't realize the pain, and I lived through pain the next couple of weeks, and it was having to take Tylenol, but I was bound and determined not to take another opioid ever again, and I haven't. But I'm here to tell you now I can do yoga, and I can do stretches, and I can do things that I could not do while I was taking my own prescribed opioids. And I thought that they were helping me, and they were actually causing more pain. So I implore all of you, if you do have prescriptions, try to wean yourself off of them with over-the-counter medicines, and see if you can do stretches and other things, because it really is affecting. My mother was in the nursing home, same thing. Every Sunday I'd go in, and she would let me like, oh. And I said, Mom, are you taking these every day? And she said, yes. I said, no more, take Tylenol. Now I go in there every Sunday, she's never hurting. It was the opioid causing the pain. So those of you, I am not unsympathetic. I got pain pills or patches, and I got the injections. So there are alternatives. I don't want to take those away from you, but I hope that you will look into your other alternatives for yourself. I'm not trying to take those away.
Yeah, I know we have another audience question, is that correct?
Yes, and this kind of bleeds into enforcement, which we will get into later, but in terms of the problem here. What is being done to prevent fentanyl from entering the U.S.? Do we know of the FDA maybe being responsible for where we are today in terms of that, drugs entering the country?
Well, there are 2 types of fentanyl. There's legal pharmaceutical fentanyl that's done by J&J or some other big pharmaceutical company that actually serves a medical purpose. It's about 100 times more potent than morphine. So it's an incredibly powerful drug, therefore highly addictive. It is for breakthrough pain, primarily for people with cancer and other issues, potentially terminal issues. That's the fentanyl that the FDA regulates. Then there's the garage store fentanyl, the illicit fentanyl that's being manufactured for the most part in Chinese labs, but also in Mexico and some domestically. And then what they do is they'll buy a brick of it for $3,000 or $4,000, $5,000, and then they use a razor and they cut it and mix it with a little heroin to make it so that the heroin, which costs more, can last longer. But there's one time I was at the State Crime Lab. State Crime Lab's under the Department of Justice, and we have a toxicology unit where the scientists will analyze the crime scene evidence, the heroin. And they come in little packets, almost like BC powder, for those of you who know what the BC powder is. And they're branded. I mean, it's just like you would think from some store. And they put them in these little egg containers and test each one. And the screen was showing just wildly different numbers. And I said, what's going on? And she said, it's because you never know how much fentanyl is in a single packet, because it's being done by these people with razors. And so one may have just a teeny bit, and the next one may have enough that kills you, or it may be an especially potent form of fentanyl. So that's what we're worried about, the illicit fentanyl. It is very difficult to stop it coming here. We should say we want it to stop. That means China has to do a better job policing its pharmaceutical companies. It gets shipped through the mail. We need to have ways of testing all the mail, but that is incredibly expensive to have mail subject to testing for drug residue. It comes in through trucks at the border from Mexico. Again, we need to do a better job at interdiction to stop it from coming in. But really, if we are ever going to solve this problem, it means we have to have people in this country not demanding the drug. And the way you stop the demand is you have zero people with this addiction. And that means having good prevention efforts with middle schoolers so that they understand the risks and don't have the desire to experiment with drugs. It means that you have a better job of locking up medication. It means getting the old medication out of your home. It means talking to your doctor about pain and what are ways to treat pain that is real. And if we don't treat pain, that leads to addiction and death too, to make sure we adequately treat people's pain. But it also means we've got these tens of thousands of people who are struggling with addiction today. And that's where the treatment Dr. Schilling mentioned and where we're completely failing as a state and as a nation. We've got to prevent people from becoming addicted and treat people who have addiction. And when we have that kind of situation, when we get it as close to zero as possible, that's how we'll save lives.
All right, well then let's transition to prevention, because that is next on the list after problem. And again, this is one of those things where we could spend several days talking about each one of these headlines here, but we want to make sure that we can move it along so that we can get to each one of them as well. So prevention is next, and Megan Malaris has this story about prevention.
Yeah, so there's definitely some strategies we can use.
Helping out paws, not handing out pills.
Looks like he's about 15 weeks old now.
It's Dr. Janine Oliver's unspoken philosophy for pets and their people.
There you go.
Did you ever think that one day you would be on the front lines of a human opioid epidemic?
So the only thing we were told about is if you have a personal problem, there is a way to get help. That's what we talked about in school. We didn't talk about, our effect on the human opioid problem.
Yet in the last 5 years, she has noticed an uptick in red flags from pet owners.
Sometimes they'll come maybe from another animal hospital and they'll say, my pet has anxiety and the only drug that works for them is drug X, and it's a controlled substance. 2, they're running out of their prescriptions way faster than they should.
The trend is why on June 1st, all North Carolina veterinarians became subject to the North Carolina STOP Act. It became law in 2017, regulating the frequency of controlled substance scripts and who gets them.
There was never a limit on what we could prescribe before.
But the new law is a start towards stopping the problem.
Not protecting our pets, protecting other people's pets, protecting ourselves.
By prescribing prevention, not pills, to cure the future.
All right, so with more on prevention, please welcome to the stage Angela Maxwell with North Carolina Alcohol and Drug Services.
Good afternoon. I really appreciate this opportunity to be here. A lot of my notes have already been stated from the panel, but we're going to move forward. I would like to start by saying that in order to effectively address the opioid crisis that we're facing today, requires a comprehensive approach. It includes prevention, treatment, recovery, law enforcement, as well as addressing laws and policy that impact our local communities. My focus is primarily on primary prevention. So when we think about prevention, although it supports treatment and recovery efforts, is uniquely different than what most people consider to be prevention, such as harm reduction, as well as relapse prevention. Our focus is how do we stem the tide of individuals, particularly young people, who are flowing into the pipeline towards this opioid crisis. And so when we think about prevention, it looks at the why behind the epidemic. So why are we seeing an increase? Why is it that young people perceive that prescription medication misuse is safer than using illegal drugs? Why do we see an increase in overdose deaths? And we've gotten a lot of that information. And so according to local data and statewide data, some of the whys in the state of North Carolina includes low perception of harm among our young people. Nationally, we know that at least 2,000 young people every day begin to misuse prescription medications. Out of that 2,000, we know locally, i.e. in Gifford County, that 5 out of 10 young people who misuse prescription medications said that they received those or got those medications out of medicine cabinets in their homes or unlocked spaces. And so 8 out of 10 adults within our local community says, we don't lock up our medications. Why? It's our home, so I can put my medications wherever I want to. But that increases access and availability, which is another one of those risk factors in the whys that we address within our community. Also, we look at the why around prescribing practices, not only around with our doctors, but also around with our dentists as well. And so statewide, some of the current efforts that we're seeing that's designed to prevent address the opioid crisis from prevention efforts includes the Lock Your Meds campaign, which is a communication campaign that has been in place for the past 2 years it is designed to encourage people to monitor, secure, and dispose their medications safely. We understand that statewide there are over 50 coalitions as well as 26 prevention organizations that are working towards addressing this issue, along with our law enforcement and other key partners. Within this campaign, over 2.5 million individuals have received Lock Your Meds information through radio, print, as well as TV ads, as well as local community efforts such as health fairs. In addition to the Lock Your Meds campaigns, we've seen over 16,000 medication lock boxes distributed, as well as over 900,000 information cards disseminated to our community, with the hopes that the general community will recognize that they are a part of this process, that it's not a us versus them issue, but we all have our part in addressing this crisis. In addition to the Lock Your Meds campaign, there have been several safe prescriber trainings provided to medical professionals to look at alternative ways of dealing with pain management. We understand that narcotic pain medication is key. However, there are alternative ways to addressing that issue. We're also advocating for increased use of the controlled substance reporting system that doctors and medical professionals can access to ensure that someone is not doctor shopping or trying to take advantage of the pharmacy system. In addition, we talked about youth. Statewide, providers are providing evidence-based prevention programs that are helping young people recognize the risk associated with misuse. And in the past year, over 22,000 school-aged young people starting from pre-K all the way up to 12th grade have received evidence-based educational programs. So we understand that this addiction issue, this crisis, is a powerful force. But within the prevention arena, we also understand that a collective effort is and can be more powerful. So I thank you all for your time.
All right, so we have, again, panelists up here, and we have this front row of some experts as well. And I think we're going to start with you guys this time as we start some of the questions that we kind of have in our minds already. For those of you who are at home watching this on Facebook Live, remember you can ask questions through Facebook Live right now. For those of you in the audience, if you need one of these index cards, we have these index cards and pens so that you'll be able to get your questions answered as well. If you just raise your hand, we'll either collect them or give you another one. All right, so with prevention, Tahisha, I don't know if you mind just being here in the front row. Let's see maybe who might want to tackle this. How do we do this? How do we prevent? How do we keep people from abusing these opioids? Chief, I'm kind of looking at you.
I will tell you, that's why we have the partners, the service providers, the teams that we formed and that we work hard with. We've got the experts in the room that know that part. We are on the front lines, and as I get to talk a little bit later, I'll talk about our role in connecting people with those resources, but it's vital. It's starting off in the elementary schools, it's dealing with our kids, and it's educating the families, the adults in the house, and the whole program is what it's going to take put together for us to actually be successful with the prevention efforts.
All right. I was wondering if there was anybody else on the front row. Otherwise, I was going to go to Chase, because I think to myself, Chase, when I heard this at the beginning, I thought of you because you have been a user and you are now recovering. And so how would we have prevented that?
I think I get asked this question a lot, and I try and say this everywhere I talk, and I ask people what the gateway drug is or what they think the gateway drug is. And you know, most people will say marijuana, right? Some people will say alcohol or tobacco. The real gateway drug for people with chaotic drug use or problematic drug use is trauma. What we have is people that have unresolved trauma from childhood especially. There's something called an ACE score, an adverse childhood experience. And scientists have studied this widely across the nation. And by using this score, you can predict someone's likelihood that they'll be an IV drug user. A person, it goes from 0 to 10, 10 being the most adverse childhood experiences. A person with a 6 or more is 4,000 times more likely to be an IV drug user than someone with a score of 0. So what we're dealing with is unresolved trauma. I know for myself, trauma and unrecognized, undiagnosed mental illness is what I grew up with. And what I did is I medicated that illness. I medicated those symptoms with drugs, and it worked very well. In fact, illicit drugs probably saved my life on multiple occasions because I did not have access to mental health care. I didn't talk about that because we're not supposed to, right? It's so stigmatized. So what I can say is for prevention for myself, what it would have took is good, solid connections with people that I trusted, that I could talk to about these things that happened, that I could talk to about my feelings or these symptoms I was experiencing, normalization of the symptoms and stuff I was experiencing. I thought that I was incredibly odd for feeling the way that I did, as a lot of people do. And there's really no outlet, especially when I was growing up, or anywhere to talk about or even know about it. I mean, I didn't know what depression was. I didn't know what anxiety was. I didn't know what bipolar disorder was. I just knew it was those folks, and it wasn't me. It was those folks over there, you know, like that family member we don't talk about or we talk poorly about, call them crazy. And it certainly wasn't me. So I think we need to do a better job of addressing these things in childhood if we want to deter problematic drug use down the road.
Dr. Schilling, I'm thinking that you have a response to this as well.
Yes. Yeah, I think what was coming to mind when Chase was talking was stigma. Being a counselor and a mental health provider and a clinical addiction specialist, stigma is very real and is a huge barrier to treatment and supportive services. And as it relates to prevention, not just substance use prevention is important in this context. You know, we're talking about trauma prevention as well. And there's a lot of education and there are a lot of great prevention programs that start very, very early that a lot of these wonderful people are working on, but are really crucial. And then that stigma piece of trying to fight assumptions about people and assumptions about mental health and substance use, because when it comes down to it, we're all just people, you know, all just people.
Okay. Tej, hold on one second for me, because I think we had a question that we wanted to make sure that we got you panelists to discuss.
So in Megan Malaris' story, she talked about the STOP Act. So one of our questions was following that, because a lot of people were saying, doctors, they're kind of on the front lines, overprescribing, things like that. Is there any conclusive data regarding restrictions that the STOP Act initiated?
I can address that as one of the champions and authors of the bill, the law. If you look at this crisis, it really originated from the late 90s through about 2010, 2011. And there was a fourfold increase in the United States in opioid prescribing. There was a fourfold increase over the exact same period of time of overdose deaths. So there was almost a one-to-one correlation that increasing in prescribing led to increase in overdose deaths. The more people who are exposed to these pills, who have the trauma or the biological tendency toward addiction. Not every person has the same genetic makeup. Two people could take the same drug, one could become addicted and the other never would. It is purely a matter of math. It is an equation. The more people who take the pills, the more people who become addicted to the pills, the more people who overdose and die from the pills. Now, Steve did a good job at the beginning, and Chase noted it as well. Over the last few years, there's been a change because of fentanyl. But 75–80% of people who go to intravenous drug use, heroin and or fentanyl, start out having been addicted to the pills. That's why the STOP Act really goes after overprescribing, because this problem really is born out of practices by the pharmaceutical industry in the 90s, in which they represented to doctors that the most effective way of treating pain, like Susan's, is opioids, and don't worry, it's not addictive. And it turns out neither of those things are true. There are so many other ways that are better at treating pain than an opioid pill, because all the opioid pill does is block the sensation of pain. It does nothing about the underlying problem in your body that creates the pain. And so we have to do a better job as society at treating pain. But that's why the STOP Act was targeted at overprescribing. So that's good and important and necessary. And we've actually seen a 25% reduction in pills prescribed in the last 2 years. So that's progress. And over time, we will see a reduction in the number of people who misuse the pills. But we have so much more to do. We have to educate children about when they have these challenges in their lives, how do you deal with that? Do you deal with it by engaging in substance misuse, or do you find an adult you can connect to or a friend who you can build a relationship with and have a healthy, positive response to that? We have just embarked on a campaign, and FMY is a partner, More Powerful NC. It's a wonderful resource, and it's available to everybody here, morepowerfulnc.org. And it is chock full of information. So if you are a principal, school board member, superintendent who wants to find a curriculum to bring into your school to help young people, it's there for you. If you're a chronic pain user and you want to know what can you do to protect your medication from being stolen by family members, there's information for you. If you're just a person who got overprescribed pills and you need to get those pills out of your house, there's information about where you can take those pills to safely dispose of them. No matter who you are, if you're a business, what you can do for your employees, if you're a church, what you can do in your community. No matter who you are, what your role is, there is a place for you in this fight against this crisis. And More Powerful NC is chock full of that information.
Did you have another question from the audience?
Most are treatment enforcement.
Okay,
from here.
well, we had some in the audience say they've noticed that some of the panelists have been saying substance misuse instead of abuse. Is there a difference? Are they interchangeable?
That's right where I was going. Both of my children had all 4 wisdom teeth cut out of the bone within 1 week apart. Both of them were prescribed Vicodin, and both of them got infections and had to have a secondary prescription. This was long before they ever learned to steal them from me. Both of my children, my son, he's an Eagle Scout, morally sound, but he told me, I had no idea until I had the Washington Post in my living room. I heard it for the first time and was humiliated, but he had started taking pills too. So ADHD meds, they were sharing pills in school. Kids can, on the bus, learn about them as first and second grade. What we didn't know was our children know how to get pills from grandma breaking her hip. And grandma, they never want to go see grandma, but she breaks her hip and everybody wants to spend the night with her. They want to spend the night with her because they can take their phone and they can take pictures of all her pills, and they can know before we do every side effect and what each pill will do and how long it'll last. They know more than we do because they grew up with the iPhones. This leads me to a story driving down 421, and I looked at my daughter and she was in recovery. Actually, she was past the recovery where she was in relapse. And I was crying driving down the road, and I said, baby, if I could do anything, I would change. I would take your rape. I would take your addiction. I would take every trauma and take your abandonment and divorce and everything, and I would own that and let you be free. And she said, Mom, I know you would. Nobody else in the world would do that, but you would. But she said, it's not your fault. And you're beating yourself up, and you're taking all this guilt. And a lot of parents didn't have that conversation before their kid died. Tori, I was gifted with all these conversations with her where she opened up and told me how bad it was. And she was honest with me about when she took my pills or when she did this or that. And it's not something that they want to do, but she was the one that told me, I know more about your pills than you do. And I'm like, no, you don't. And she said, yeah. And she would show me on her phone, and she taught me. We need to have the conversation. Also, I'm on the state CFAC, and we had a meeting this morning in Raleigh. I drove here from that. They had the charts on the screen today on the difference between self-reporting from children and the reporting of adults about their children. You would not believe the disconnect. We look at our kid and we have no idea because they're smiling, they're smart, they're doing all the right things in school, they're making straight A's, and we are so disconnected from the social isolation. And that is a key thing. Kids need the love, affection, attention, but they need the human touch. Divorced families, I am one. I didn't do that well. But all these things, those are what he was talking about, the ACEs score, the childhood traumas that we don't think about, the divorce, poverty. When I broke my back, we didn't have food. I had to go to the food pantry. I don't look like I ever went to a food pantry, but I'm telling you I did. And all these things hurt these children. I yelled at my daughter because she asked me for 50 cents for school, and she had asked me for $3 the day before, and I didn't have it. But I yelled at her, and it wasn't her fault. But the stress that parents have when two parents work or they're divorced and they're single parenthood, all those traumas, that's what's killing our kids. They're hurting inside.
Appreciate you. Thank you. All right, we are going to move on from the problem and prevention to now let's talk about treatment. Let's talk about recovery as well. For those of you who are just joining us on Facebook Live, you can ask your questions to the panelists and also the experts that we have here at the Town Hall. You can watch on YouTube as well at WFMYnews2.com. For those of you who may be joining us live on TV right now, the Opioid Town Hall has been going on since about 4:30 this afternoon, and we have a live audience here who is also able to ask questions of the panelists, but we invite you to jump on Facebook right now to ask your questions and get in on this discussion. All right, so now to treatment and recovery. This is a story that I was able to put together of a woman who I have known for the last 5 or 6 years who has been recovering successfully for the last 7 years, and how she has been able to do that. I want to introduce you to Brandy.
Every day you take the top off, drink your medicine, just like a medicine you do every day, you know? Bite them and everything.
This routine of a daily dose of methadone has kept Brandy alive and clean for nearly 7 years.
Methadone, people look at it as a bad thing, but it's really not. To me, it saved my life.
And it saved her family. As a mom of 5, Brandy stopped using because of her kids. This is from an interview of 2014.
If I'm not clean, then how am I going to be a great mama? How can I be a better mama?
In 2016, we caught up with her again. She was taking the bus before the sun came up. just so she could get her clinic appointments in.
If you're going to go in recovery, go all in, head in. You can't just say, oh, this medicine's going to make me clean. You have to have your mindset. You have to want it.
I was so impressed with her. Every time I see her, I'm impressed with her because she just says you have to want it. Okay, so we are live on WFMY News 2 right now. We want to welcome all of you who are watching right now. This is our live town hall for the opioid crisis. We have a list of panelists here, and we also have a live audience as well. And we want to invite you again to share what your comments and questions are. You can do that right now on our Facebook page. All right, so as we are talking about treatment and recovery, one of our panelists, Dr. Elizabeth Schilling, who you've heard from a few times from Wake Forest School of Medicine, is going to take a look at that for us.
Good afternoon. As mentioned, I'm Elizabeth Schilling, and I work at Wake Forest School of Medicine and Baptist Health, so both with the sort of education piece and the hospital. And so I'm going to talk to you a little bit today, just really a high-level overview of treatment and recovery to get us started in our question portion. If you can go to the next slide. Thank you. So first, to get us started, and sort of related to some of the questions that I heard earlier, I think it is important to differentiate an opioid use disorder, which would require treatment, and opioid use, and other substance use that's not at the level of a use disorder. And that's a very clinical term, but it's important to know that an opioid use disorder includes symptoms that someone who is using a prescription opioid as prescribed is not necessarily going to experience. And so knowing how to sort of conceptualize an opioid use disorder is important to talk about treatment and recovery. So there are a bunch of symptoms that fall under opioid use disorder, and they fall into 4 categories. And those 4 categories are impaired control, social impairment, risky use, and pharmacological. And so when thinking about those 4 categories, impaired control might be something like spending a lot of time seeking drugs out and using drugs. So, and that's at a level that is causing dysfunction in your life. Social impairment might be a situation where you fail to fulfill a role obligation. So one of the questions earlier was about employment and risk factors. And so if someone is coming in late frequently to work, is getting written up for falling asleep on the job, different things that would indicate something's going on with that person, lots of things might be happening there. And so not making an assumption that there's a substance use problem is a good thing. But also to understand that there are role obligation risk factors associated with a substance use disorder. Risky use includes things like continuing use despite physical or mental health negative consequences. So one of the things we do sometimes see with individuals who use IV drugs are infections. And so continued IV drug use despite like a heart sac infection is a symptom associated with opioid use disorder. And then finally, that last section, that pharmacological and withdrawal piece, or that pharmacological one includes tolerance and withdrawal. And so tolerance is when you need more of a substance and you need it more frequently to experience maybe even baseline, as Susan mentioned earlier. And then withdrawal is when you stop using a substance, or when you even sometimes aren't using at that same level, you're going to experience some pretty substantial negative physical symptoms like nausea, vomiting, runny nose, diarrhea. So all of those are symptoms that we associate with if you combine those together in opioid use disorder, or really any substance use disorder. If you want to go to the next one. Thank you. So that's all to say that once somebody is diagnosed with an opioid use disorder, they can seek treatment, and there are lots of different kinds of treatment. Treatment is intended to help people stop using and stop seeking drugs. And treatment occurs in a variety of settings and takes on lots of different forms. And really, people need a lot of different options because, you know, we're all so very different that one thing is not going to work for me in the same way it's going to work for you. So typically, treatment is more a long-term process for a substance use disorder and can kind of go on and off. So you might need to seek treatment out more than once. Treatment includes counseling and behavioral therapies, medications, and supportive services. And this image up here on the screen is from the Pew Institute and demonstrates the 4 FDA-approved opioid use disorder medication treatments. And so those include buprenorphine and Suboxone, methadone, which is the one that woman mentioned earlier, naltrexone, and naloxone. And so those are 4 FDA-approved medications to treat opioid use disorder. And finally, when you're talking about treatment, you have to talk about levels of care. And what that means is that depending on the severity of my substance use disorder and a lot of things involving in my life, I'm gonna need a specific kind of care. So that might be outpatient therapy. That might be an intensive, medically managed inpatient treatment that lasts a couple of days, a couple of months, whatever it might be. But there are lots of different levels of care for that. Next one. So when we're talking about treatment, it is really important to talk about cost and availability. And I know I mentioned that earlier, and that's probably going to be what I keep on coming back to. But treatment for addiction can work. It does work. And it is less expensive than the consequences of addiction. An Institute of Medicine study recently looked at the cost per person per year of treatment. So for outpatient, it was about $3,100, and for residential, it was about $12,000. So that's per person per year. That's a lot of money. $12,000 is a lot of money. I mean, that's like a half of a car, or getting you pretty close to a really nice car sometimes, whatever it might be. But when you're looking at a non-treated individual who has a substance use disorder, the cost is estimated to be about $43,000 a year. So treatment saves lives and is cost effective. If you go to the next one. So, and treatment leads to the opportunity for recovery. And recovery really is, I like this definition from SAMHSA, which is the Substance Abuse and Mental Health Services Administration. Recovery is a process of change through which people improve their health and wellness, live self-directed lives, and strive to reach their full potential. It goes beyond just remission of symptoms to include a positive change in the whole person. So abstinence doesn't necessarily mean somebody is in recovery. Recovery means lots of different things, and that story we just heard really highlights that. And I think what I want to highlight the most here is that a person's path to recovery and what their recovery looks like is individual and is going to be different for every person. And to respect that this person's definition of their own recovery is just as valid and important as this person's. Finally, recovery supports work. We know that 12-step programs are evidence-based, that peer support specialists and recovery coaches really help people maintain recovery and really can help them through that treatment process. Thank you.
All right, so I just want to bring everyone up to speed, especially those who are joining us live on TV right now. Our town hall has been divided up into several different areas. The categories: the problem, prevention, treatment or recovery, enforcement, and then what's next. And for each one, what we have done is we have set apart what that issue is. We've kind of told a story that highlights someone who has been living in one of those kinds of categories. Then when we come out, we're able to learn a little bit more about whatever that issue is. Then the panelists are then taking some questions, but then what's happening is we're getting your questions, your discussions, your comments, your ideas. So as you're listening to this live on TV right now, live on Facebook right now, you're able to ask questions via our Facebook page. And then we have folks in the audience who are submitting their questions, their comments as well, so that we can get this discussion going. So we are on the discussion part now about treatment and recovery. And Tahisha, I understand that you have several different comments and questions. This has been kind of like the bulk of the questions and the comments from the audience.
All right, so I'm trying to find the exact question, but we have had a lot of questions geared towards children and those who are under 18, and how are we able to get them help specifically? Someone mentioned HIPAA laws that were hindering them from getting their kids help as well. So I know we're talking about teens getting their grandparents' pills, but once you see that they're on those pills, what do you do as a parent, as a friend, to get them the help that they need?
I think that I've been listening to the conversation and just absorbing what's going on. I think that we really got to understand this opioid epidemic that we're talking about. We got to really understand that there's a financial component that drives this. As the AG talked about, the more people that get exposed to it, the more people become addicted to it. But at the same time, the more people become exposed to it, the more money the manufacturers and distributors make. We talk about this opioid epidemic. We talk about it from a cure point, but we talk about it from a suburban perspective rather than a systemic perspective. Opioid epidemic involves cocaine use in the areas that the chief and I and the other departments deal in every day. So when we look at this opioid epidemic, we've got to look at it from a systemic and a holistic point of view. That's the only way we're going to deal with this. I can tell you that firsthand from being in the places in the den of the demon, as they call it, from the cities that shipped them here, from the countries that shipped them here. We cannot approach this from just a one perspective or one dynamic. It has to be an all-hands holistic approach. Any epidemic that kills 70,000 people per year has to be public enemy number one. And until we address it as that, we'll be having these same conversations over and over with a new set of faces. Because the problem is that we all got to take ownership. If you look at it from the same way the tobacco industry, back when I was growing up in the 60s, you know, they had the commercials, the Marlboro Man, it was cool to walk a mile, the Virginia Slim lady, how it was cool to do certain things, and you bring it forward to now we're talking about opioids, we're talking about pills, you're talking about the money that is being made, $1 billion industry, $1 billion industry that is being made in terms of the illicit drugs on the street, the shootings, the killings that we have in all of our neighborhoods that are driven by so many different things. So when we look at this prevention thing, it has to be everything from the clergy to the school teacher to the custodian. It has to be everybody involved. So when you talk about, I heard you say something about the kids, how do we deal with that? So as we were saying earlier, we have kids as young as middle school that are trying drugs, right? And they don't all come from parents' homes. They don't all come from there. We have a drug trade that is vibrant in this country, in this community. So when we start addressing these issues, we have to have real conversations. We can't have departmental conversations. They have to be holistic conversations where all hands are on deck.
I think to speak to the availability of treatment for children and teens, especially children and teens, we have even fewer resources. There are still resources, though. So if an individual is hoping to find treatment for their child, there are websites that you can go to. So SAMHSA's website has some treatment providers listed there. You would want to look for a licensed clinical addiction specialist to be able to assess the situation. In our own community, Moses Cone's inpatient mental health has a child part where I did a wonderful internship and worked there for a little bit. And they can provide assessment and short-term treatment and then connect those children and teenagers to future treatment as well.
On treatment, frankly, we as a triad, we as the state of North Carolina, we as the United States, we're failing. There's no other grade than an F to give ourselves in this regard. And if you have a child who's addicted, it is incredibly difficult to find a place. An inpatient, I think there's one inpatient facility for teenagers in the entire state of North Carolina. Why are we failing? Because treatment is healthcare. Healthcare costs money. People need a way to pay for their healthcare, and that's insurance. And yet, we have 1 million people in this state who don't have any health insurance. My office was arguing in the Fifth Circuit just to defend the Affordable Care Act from being eliminated in its entirety, and about 500,000 people who have health insurance under that's at risk. 40% of all treatment dollars comes from Medicaid. The single most effective step that the state of North Carolina could take to fight the opioid epidemic, of all the 30 things we're going to talk about today, the single most effective thing we could do if we cared, if we were serious, would be to accept the federal government's offer to expand Medicaid, because it would give 500,000 people who do not have health insurance. And when you have health insurance, you can then pay for care. And if there's a way for a provider to receive payment, then they will provide it. But we cannot expect doctors and nurse practitioners and PAs to do work for free. People need to have a way to pay for the treatment. And until we find a way to solve that problem, make sure that people have health insurance, we are going to never solve the crisis.
Not also make sure that they have health insurance, but also make sure that that health insurance also covers recovery and treatment.
Good point.
And to get them to that point of getting help, stigma. A lot of times people won't get help, and most of the time it's dual diagnosis. There's always an underlying trauma, whatever it is. People don't just get hooked on drugs without some other stimulus that is causing the underlying trauma. Like I said, my 2 children both had opioids, and one got addicted and one didn't. And one would never touch him again. He saw his sister die. But the over and under of 18 years old, to go back to what was told about the HIPAA laws, that was an obstacle, because before my daughter was 18 and I had the knee-jerk reaction like days before her 18th birthday trying to get her help, and you can't do anything when they turn 18. You have no say. You can't see their records unless they let you see their records. So I don't know the magic potion here for what we do, but most children that are becoming victims to the opioid epidemic are after high school. A lot of them don't ever touch heroin until after they leave high school. It's like a cliff. They've always had something to do and somewhere to go and a goal. Graduation, 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 college. They fall off a cliff, and we're losing them. And 22 to 26 is our peak deaths. So it's after we have any control over their lives. So there's got to be some way to get connected so that they will seek help and to get rid of the stigma, so that we all, because I was ashamed. I wouldn't tell anyone. It was not until her death that I was able to come forward. And the faces are we put faces on our Teal Drops website because those faces are important. The numbers are great and they're powerful. There's nothing more powerful than seeing your child's face and hearing the story about who they were before this horrible thing took effect.
So I guess my question then is, what is the best way to find the right treatments?
We have a website, morepowerfulnc.org, and there is a tab which says Get Help, Seek Treatment. And it has links to SAMHSA's webpage. It has links to other resources which can connect you to treatment. The problem is, and so go there, More Powerful NC, Get Help. The problem is there's not enough. There are waiting lists, or people can't afford it, but there are resources out there. And the tragedy of all this, as the doctor said, is treatment works. It works. It helps somebody with addiction end up in recovery. We just need to have more people have the opportunity to get it.
Yes, please. Hold on, let's get the microphone over to you so that you'll be able to also address this concern as well about treatment and recovery.
Hi, my name is Matthew Motzinger. I'm a community paramedic in Forsyth County. We've actually started to explore new ways to connect people with treatment. From the scene of an overdose, when somebody was dead 15 minutes ago in full respiratory arrest, we give them Narcan and get them back to the full advanced life support procedures. But we've also developed a team to go out and to every overdose that happens within Forsyth County, and we offer them aftercare. We offer to do a full-on assessment with them to address their addiction issues, to do what we can to maybe, after law enforcement's been there, after the fire department's been there, we kind of stay with them after that overdose, or, when they're in that addictive crisis, to really say, hey, look, are you willing to go to treatment today? And if you are, we'll call around. We'll look for beds. We'll give them we'll transport them over to the treatment facility. We'll see about inpatient, outpatient. We'll do a full-on assessment. We'll call them the next day. If that's not the moment they're ready to seek treatment, then there are other options. So, and there are programs like this out there. We'll leave Narcan kits with those individuals. We'll also provide them with a list of resources, and then we'll call them the next day, or they have our contact information. So we try to bridge that gap into a connection to resources. And it's been very beneficial in our community so far, and I'd like to see more programs around the state go ahead and try some things quite like that. I know one of the biggest barriers that we continue to run into, just like Dr. Schilling said, is bed availability, and sometimes staffing. Some of these places have big buildings and lots of shiny toys, but they don't have people there to use them. We don't have trained mental health clinicians or addiction specialists, or the physicians or nurses that are needed to do that assessment. And I love my ERs to death, and I've been a paramedic for 15 years, and the ER is not the place for someone who's like that, who's in that addictive crisis or in that mental health crisis. They need to speak to someone who's a trained mental health clinician or in the mental health field, and that diversion away from having to spend 8 to 10 hours in an ER just because you're not having a STEMI or a stroke or a trauma, you still have a crisis as well. So we need to be able to facilitate that connection to that specialized resource as much as possible.
So, like for Brandy, for instance, I think a lot of people think that maybe treatment takes a week or so. You withdraw, you no longer have that, you're fine. And that is not the case. I mean, she's been on methadone for 7 years, and she's like, I could be on it for the rest of my life, but at least I'm living clean. So, but you think of that and you think you can't just get treatment for a couple months and then life goes back to normal.
It's a chronic illness. I mean, people have other forms of chronic illness, diabetes, and they take medication for the rest of their lives. Or if you have heart disease, you will take medication for the rest of your life. And so it's a sickness, and some people need the medication for the rest of their lives, others don't.
So that is a awareness of healthcare industry, yes, to make it a sickness so that it can be treated, but then also state, federal, county, city dollars to have treatment places to make that happen as well. Okay.
I'd like to add something if possible. If you live in Guilford County, if you simply call 336-505-8122, that's the number for our program GC Stop. We do post-overdose follow-up as well as other harm reduction strategies here in the community. We have a whole team of interns and people with lived experience, social workers, addiction specialists, who guide people through the treatment process. And it's really as simple as giving that number a call or a text. It goes to my phone. I may not return it right away, but within 24 hours, someone will return your call from our team and help that individual. And like it's been mentioned, we do have a huge problem with treatment in this country. The main problem is that the vast majority of folks who use drugs do not want to be abstinent. They do not want to be abstinent from all drugs, and that is a requirement for the vast majority of treatment programs in our country. So what we have is people that are ready, going into treatment, doing their thing, and a lot of folks do get better from doing that. But that leaves a large number of people untouched, and these are the people that are most vulnerable. These are the people that are at highest risk for overdose death. So we have to change the treatment paradigm. We have to start giving folks other options, stop mandating that they do the things that we want them to do. A lot of the treatment programs locally have lots of stipulations about them, and we try and get folks in there, and they don't meet eligibility, or they don't have transportation, or they can't do a group 3 days a week. They can't do these things, so they're denied medication. Could you imagine someone with diabetes going to the doctor and saying, I need some insulin to manage my blood sugar? And the doctor says, okay, that's great, but you also have to meet with this nutritionist, and you have to come to this group 3 days a week. Well, I can't do that. I've got to work, or I don't have transportation, or I simply don't want to. Okay, well, I'm sorry, we're going to withhold your insulin from you until you comply with the rest of our treatment. So we have a huge problem with treatment in this country, the regulations around it, the way we do things. That being said, I do encourage folks to try treatment. And like I said, there are people out here in Forsyth County and Guilford County who will personally navigate that process for you and try and overcome those barriers with you. and we are here to support one another.
Hey, Chase, I want you to be able to say that number again, because there may be people at home who are watching live on TV. You might be watching live on YouTube or Facebook, or those of you in the audience, and you weren't able to jot down that number. So get your phone out, get that pen and piece of paper, whatever it happens to be. And again, what is that number?
The number is 336-505-8122.
Great, thank you so much, Chase. Tahisha, did you have another question or comment from the audience or from Facebook? Mm-hmm.
Yeah, another comment, someone was saying their son needed treatment, called 34 centers, couldn't find a place. So that just goes to show the limited availability of beds. They had insurance, still struggling to find a place. That was from someone on Facebook.
And what do you do when you're that family member who is so trying to help the other family member? There's no easy answer there. Okay.
So here's another one. I work for a national diagnostic laboratory and work directly with providers such as primary care and pain management to educate them on drug testing to ensure compliance with prescribed medications and support the STOP Act of North Carolina. One thing I hear is that once a patient breaks their contract through the findings of the result in their drug screens, they will dismiss the patient from their practice program. Do you feel this has led to the increase of illicit drug use and overdoses, such as heroin and fentanyl? If so, any ways to combat this?
It's a pretty complicated question in that there are lots of different, I think you can try to explain something by saying this caused this, and that's not always going to be the case. If a patient is let go from a practice and they have developed a reliance, a dependence on a medication, that could present challenges for them because they will start to experience withdrawal symptoms. And when individuals start to experience withdrawal symptoms, withdrawal is not like your common cold or anything like that. It's pretty painful and uncomfortable. And when individuals experience withdrawal, they're not going to want to be in that space, and it's going to push them into looking for ways to deal with that. And I think, we mentioned earlier that sort of our system's kind of pushed really far to, okay, well, we need to not prescribe opioids at all for pain. We need to really, pain is, we're not handling that as well. But when you're in sort of that stigmatized place of I have chronic pain, I don't have a provider now because I maybe misused another substance. So it's really common for individuals with chronic pain to use marijuana sometimes to kind of control some of the pain that's not being controlled by an opioid, because we know opioids don't do a great job with that. But that can present really substantial challenges for that individual, and they may not have outlets that are what we would hope for them. And so no, it's not great. It may not lead to that, but it could cause problems.
And another question someone was asking, they wanted to know about your journey, Chase. You said you recovered, so they want to know how you got to that place.
Sure. I get asked this a lot, and I can only share my own individual experience with recovery. And I wish I had a magic answer for how everyone could enter into recovery. What I can say is that no consequences made me want to find recovery. Consequences further challenged me and got in the way. What I can say is the privileges and opportunities afforded to me greatly increased my chance to find recovery. I was able to go to a private treatment center, actually in Greensboro, North Carolina, Fellowship Hall. A fantastic place. They're abstinence-based, and I went there, and since then my life has been pretty good. It was my second time in treatment. But I think the main thing that happened for me is that after my head was able to be cleared a little bit, I started to meet other young people in recovery, or other people in recovery in general. I had no idea that people got better, and I thought that if people got better, it certainly couldn't be me, because I had tried time and time again to quit. And like I said, I have the allergy. I could not quit on my own, no matter how many times I tried. So that accumulates, and I started to think, well, maybe I can't do this. I thought it was my destiny to die with a needle in my arm. I really did. And then when that hope was restored, and I met other people in recovery and thought that I could do it, I plugged in, and I started hanging out with those other people in recovery. I had all the, like I said, I'm privileged and had all the other supports. I had access to a job. I was able to navigate the criminal justice system better than a lot of people. I had privileges to an attorney. I had privilege of white skin. And those things, all of that helped me to get the recovery capital that I need to sustain recovery. Recovery capital is something we talk about in the field often. What that can be is access to a job, access to health care, access to food, access to housing. And all of these things are things that most people who use drugs are systematically denied because we give them a criminal record for using drugs. So I can't find a job. I can't get approved for that loan. I can't go back to school. I can't get an apartment. I can't do all these things. So systematically, we're preventing people from having the very supports they need to have and sustain recovery. So I simply think I got afforded all those opportunities, and what I really want to do here and with my job is to ensure that everyone else has all the opportunities that I did to find and sustain recovery.
That was
Right.
awesome.
Thanks, Josh.
Do we have one more, or are we, is that into the next?
There's so many more. It's just who gets to have their answer. Let's see. So someone was asking about faith-based substance abuse centers. I'm going to see if I can pull that up. Christ-centered residential programs like Hannah's Haven, Freedom House have higher success rates than most other programs written here because they get to the root of the emotional issues that lead many to abuse. We need state funding for these programs. Right now, they strictly run on donations and more money and could help more people. So, Josh Stein, is there anything on the state level that they could do to get that funding?
The funding, the public funding that goes towards treatment comes through the Department of Health and Human Services, and they primarily use the LME MCOs, which talk about a mouthful, but these are the regional mental health facilities that have contracts with the state and provide help for people who don't have health insurance and have mental health or substance use issues. I don't know what the requirements are on that funding in terms of partnering with faith-based treatment facilities. One thing is that I think Dr. Schilling said, there is no singular path towards treatment and recovery. That for some people, an abstinence-based 12-step model is the way to go. For another person, like on the video, going to a clinic that offers methadone every day does what it takes so that she's not misusing and she's able to function in a very independent fashion. So some people need medication-assisted therapy, other people need a pure abstinence base. Some people are religious and get fulfillment by a faith orientation. Other people aren't. And there are different ways to get there, and we just have to be tolerant of the fact that there's no one size fits all. I do think that we would benefit as a society to have much more rigorous analysis of the success rates of each program. Because even though there's no one model for each, not everybody is equal, not each institution is equally good at delivering results. And I do believe that we don't do a rigorous enough job analyzing which groups do a good job and which ones don't. The problem is when you have such a desperate shortage. My God, you said somebody called 30-some facilities.
You don't want to analyze it then,
you're just
want them to be
desperate
there.
for anything,
Right.
and you will put your child anywhere. And the sad thing is that because we're human beings and not every human being is motivated by good, there are scam artists out there who will prey on people's desperation, take somebody into their facility, and turn them into practically slave labor. There was a facility that was sending people to go work at old folks' homes for no pay and getting paid by the old folks' home. I mean, just criminal behavior. So folks have to be careful, but until there is a consistent stream of resources dedicated towards treatment, we're going to fail. To that end, I think pharmaceutical companies have played a massive role in creating this crisis, which is why I have sued two. I've sued Purdue Pharma and Insys Therapeutics for their contribution to creating the crisis. I am helping to lead a multi-state investigation, more than 40 states with Republican and Democratic attorneys general combined, investigating the role not only of the drug manufacturers, but also the drug distributors, which take the pills from the pharmaceutical companies to the drugstores. I believe they have a major role to provide the resources that we as a country need to adequately tackle this solution, and that's why I'm fighting that fight.
Several prongs, okay, there. Thank you. All right, we're going to move on to our last bit here, and this is about enforcement. And so, Tahisha, actually, this is your story about enforcement. So let's take a look what we can learn from this.
It's a widespread problem plaguing our communities.
We're responding to homes, to parking lots, to businesses, to bathrooms inside of businesses.
No city is immune to the opioid crisis, and with nearly 5 people dying every day from a drug overdose in North Carolina, police say the drugs need to be taken off the streets.
Obviously, heroin, opioids are our primary focus.
Lieutenant Curtis Cheeks with High Point Police says enforcement is an important part of the puzzle when it comes to combating the crisis.
The enforcement action is to limit the availability, to hold some accountability to those people who are helping contribute to the problem.
A new bill signed into law by Governor Roy Cooper Monday could help. It's called the Death by Distribution Bill. The new law allows prosecutors to use felony charges against drug dealers who contribute to an overdose death. The felonies have penalties comparable to second-degree murder charges. It doesn't change the Good Samaritan law, which offers legal protection to a person who calls 911 to report an overdose.
All right, so with more on enforcement, please welcome High Point Police Chief Ken Schultz.
So I'll tell you in the next 4 or 5 minutes, what I want to do is actually raise the altitude of the view about what we're looking at here for your consideration as we talk about this epidemic. What we know is that one's exposure and experience really dramatically shapes your views, your thoughts, and your focus. If we talk to a family member who's lost someone, you talk about epidemics with the opioids, they're going to talk about those personal struggles. If we talk to somebody in a medical profession, they might talk about alternate opportunities, alternate options for that pain management. As law enforcement officers, our views also shape our exposure, and unfortunately, the epidemic here has provided us with plenty of information to look at. I do think that this gives us a much more complete view of the entire situation. And I'll say I'm concerned that some individuals may even view us, law enforcement, as being part of the problem, that they must deal with us while they're also trying to be out here saving those with the addictions. With the few moments I have, I'd like to talk about or expose you to what we see as law enforcement officers and let you see the full range of impact caused by this specific epidemic. In High Point, our epidemic really started in May of 2014. At that time, we encountered 32 overdoses with 8 deaths. That was up from 4.5 overdoses per month for the previous 3 months. Before that, we didn't even track this particular situation. These overdoses could be involving prescription opioids, heroin, fentanyl. It doesn't matter because our response has always been the same. The impact or the impairment level is what varied. Sometimes we ended up with people that were suffering from the physiological effects that they were actually desiring. Other times they're in severe medical need for the attention, and other times, like I noted, they were actually dead. PD took a lot of actions and a variety of actions right from the start. The biggest thing we did is we started to collect data, and I know you can't see it, but I want to talk a little bit about the data that we've been able to put together, which I think gives us an inclusive view of the epidemic. To date, since 2014, we've responded in High Point to over 1,069 overdoses. We've had 89 deaths. The PD alone has deployed 98 dosages of naloxone. Approximately 50% of the overdose victims that we have in High Point actually live outside of our city. And that's something that's critical as we look at funding resources and resources available for treatment as we can figure out how to go about addressing those people's needs as well. So these statistics alone tend to highlight the personal impact that the epidemic brings on individuals. And if we left it there, it'd be easier to see that this is a societal problem and that one, maybe that doesn't necessitate law enforcement's participation. To that point, let me expand upon it though. 57 of our overdoses have involved traffic accidents. While some of them were single car accidents, others were involving the motoring general public. Children were present in 58 of these calls that we've gone on. 30 times, they were under 5 years of age. I can tell stories about finding kids in car seats with the mother dead in the front of the car, sitting at the steering wheel. We can talk about finding the parents passed out in motel rooms with kids crawling around with needles in the floor. So as you start to see these different points, you're going to understand that the epidemic victimizes more than those that are just specifically addicted. A final aspect that is often over time looked as well is the crimes and the violence that's associated with this epidemic. While it's true that some of the addicts actually commit crimes to get the funding for their narcotics, we have some fraud involving doctors and pharmacies. This is not where the worst impact is felt. The most concerning community problems relate to the violence that goes along with the supply side of this particular issue. Many of our robberies, our shootings, our gang-related violence has an opioid or narcotics nexus involved in that. Occasionally, this violence spills out into the rest of the community as well. So when you see these three different areas and you view them in the totality of the circumstances, you're going to understand the entire impact of the opioid epidemic. It also highlights the reason for our focus. So what are we going to do now? How do we act? We continue to work with our service providers. We continue to work with our partners very closely and actually aggressively to do that. We're not governed by HIPAA. We can stand up, and we've taken the opportunity to provide information on our victims that we encounter. We share that with our service providers to try encouraging that connection with the service personnel as well. We also remain hyper-vigilant in our efforts of those supplying the opioids into our city. Big money's involved, like we talked about. Some of it even goes outside of the country, but we work closely with our federal and state partners to focus on the contraband that is being brought into our country and into our city, and on the individuals that are attempting to make money off of these addictions. The efforts include focusing on those involved in illegal diversion of the pharmaceutical drugs as well. Over the years, we worked closely with the Attorney General and our legislative body to get a variety of laws and policies passed. On the addiction side, we've been in support of the needle exchange programs and the Good Samaritan laws. We've backed the funding requests for some of these treatment opportunities. We continue to work closely with our district attorneys as well. We try to divert anything that is eligible for such actions. But I will tell you also at the same time, we have worked hard to be able to hold those accountable for the supplies of drugs, to hold them accountable. And so we've had to fight for some of the tools that we specifically alluded to in the video. So I'll tell you, it's a tough balancing act for us. We've got to strive to meet the obligations to assist those in need while also protecting our community. The bottom line is I'm going to say that this is a demand and a supply issue. And I think it's imperative that we attack it from both sides to be successful. The only way we're going to do that is through the partnerships like you see here today.
All right, let's open it up to some of the audience questions because I know we have a lot of questions on this particular topic as well.
All right, so our first question comes from someone in the audience. Drug laws have disproportionately affected minorities and communities of color. This is for law enforcement. How will you ensure death by distribution does not further discriminate against communities of color?
Chief.
More statistics. I know you guys cannot see the statistics that I had available, but I will tell you the data that we have, this is not a minority crime, a minority situation. It is actually impacting generally our white males, followed by the white females. So while race is an important consideration in a lot of efforts, our enforcement efforts are specifically geared towards those that are being victimized.
Anybody else on the panel that wanted to answer that question as well, what you're seeing?
Well, I agree with what the chief is saying is that when we see incidents of that, we don't look at it from a racial issue. We look at it at it is what it is. We deal with the crime as it has happened. While I understand exactly what you're saying because I understand the optics of how people see things based on incarceration and numbers that present themselves on incarceration. I understand that. But what I would say is that it's not a black thing or a white thing. It's a life and death thing. And that's how we have to approach it.
Thank you, sir. All right, we have another question.
Yes. How can we focus on the street-level dealers instead of high-level dealers? Seems like the street-level guys are left to keep dealing. This is from Cindy on Facebook.
So when you say the question again,
Street level dealers instead of the high level, so I guess low.
So when you talk about the drug trafficking in the street, the street level dealer gets his from the high level dealer. He gets his supply from somebody who has more supply. So when you look at the drug and the trafficking, you have to approach it from all angles. You have to approach it from the cartel level, the distributor, and all the way down to the street level dealer. You can't just attack one specific of it because it's money driven. And as soon as you take a street level dealer off the street, there's another person to replace them because, as we said, it's systemic and money is the driving force.
And I'd like to add something. Someone asked me about the person who gave my daughter the drug that killed her. And he actually gave it to her the day before, and she overdosed, and they brought her back with Narcan and then came back. He's just another person with an addiction, no different than my daughter, and his mother is no different than me. His mother is tearfully, painfully suffering through this as well. A lot of the street dealers are doing that because when you have a $300 a day habit, I don't make $300 a day. You either have to sell your body, sell drugs, or steal something. There's not really another way to get $300 to feed a habit that is so painfully sickening when you don't have it and you're so far below that to be able to function. I know a person who actually shot up with toilet water because the water didn't work in the bathroom at the gas station. When you're that desperate for the drug, when you're so sick you're throwing up on yourself and you can't even get to the bathroom, I don't really have I'm not hatefully trying to throw this person under the jail. We have to get to the people that are bringing it in, and we have to come out and try to help those at that level that may be also selling to just make enough to get the high they need to function.
Okay, thank you.
I'd like to expand on that if I could, briefly. Specifically to the law that was mentioned in the clip, the drug-induced homicide, death by distribution law. What I can say is that we work with folks that use drugs on a daily basis, about 700 plus of them in Guilford County. And I speak with them on a regular basis. Since we started over a year ago, over 500 times has naloxone that we distributed saved someone's life. We know that people have been calling EMS in response to an overdose more often because of bills like the Good Samaritan law. From talking to these folks that use drugs and from my own personal experience, I know that a direct result of this bill will be far fewer people will call 911 in response to an overdose. More people will die as a direct result of this bill, and I can't stress that enough. What I can say is I was a person that sold drugs, and I did that to sustain my habit. What's going to happen is that people, the law reads, sell and deliver drugs, and I testified in front of the Judiciary Committee at the General Assembly and talked to some of these lawmakers, and a specific example was brought up that if I went to go and get drugs for my friend and myself, he would obviously give me some money for those drugs, so I'm not going to give him free drugs. If he died as a result of those drugs, I would be charged with homicide. So what that means if that happened to me was I never would have found recovery. I would be sitting in a jail cell unless the privilege afforded to me of an attorney and my white skin got me out of trouble. I would be sitting in a jail cell and none of this stuff would have happened. I wouldn't be in the community helping others. I wouldn't be doing the things I'm doing today. These punitive things will continue to put people into the shadows and continue to make more and more people die. And I really hope that we can do something about this law and change it after we see the dramatic effects that happen. I know for myself in our program, we'll be keeping data on this and tracking how fewer times people will be calling 911 in response to an overdose. That's all I have to say about that.
Thank you, Chase.
And speaking of the law, there was a gentleman here who wanted to ask Chief Schultz if you had any numbers on the number of people that you were able to save, revive, or even for EMS here because of Narcan that you had, that the officers had.
So I was one of those ones. In our city, we've got a fire department that's almost as quick on the scene as the police department is. We've also got EMS. I stayed away from the Narcan for initially because I thought they were there. After we had officers performing CPR several times waiting for EMS to get there, we changed our plans. We went ahead and accepted some from the North Carolina Harm Coalition, again, with promises that more would come. Unfortunately, that didn't pan out. We ended up having to take that effort, that budget item into our efforts. But again, we've now had 98 saves at the police department, or deployed at least 98 times with that. And if I can respond back to the law again, in my presentation, I talked about this as a tough balancing act. I want you to elevate your views because, again, I also said that this has to be approached from both sides. If everything is focused on just the addiction, then we're not going to be able to touch the supply. And that's the tough balancing act, is where you can't handcuff law enforcement and stop the cartels and the gang activity that's bringing this stuff in as a lucrative business, and then us not be able to impact them. So the balance is going to be the discretionary side of it. It's going to be working with our district attorneys. It's going to be identifying the reason that these people were distributing the drugs, the idea behind it. I understand the concerns about individual users getting caught up in it, and we could easily say, fine, we won't charge anybody with narcotics. What's that going to do for the people that are bringing kilos and kilos into our country and flooding us? So that's the dilemma that we're in. It's got to continue to be approached from both the addiction side, the treatment side, the prevention side. We're going to have law enforcement side as well. And we've got to find that happy balance so that we can be successful and address the tens of thousands of deaths that continue to increase over the years.
And for you, this is another enforcement question, maybe Guilford County Sheriff Danny Rogers, you can answer this as well. What is being done to curb internet purchasing of drugs like fentanyl, K2 spice, et cetera? How much of fentanyl comes in through the mail? I know we mentioned a little bit of that. How's your department handling internet purchasing?
Our specific focus is on heroin because of the destruction that goes with that. We continue to work with that. We leverage partnerships. We work closely with the State Bureau of Investigation. We work closely with our federal partners, the Postal Service. We have task force officers that are out doing all sorts of law enforcement tactics and efforts to address this. It's everything from the wiretaps and the phone systems that you're watching as we're monitoring information that's going on in Mexico, across the seas, the China side. So it's a holistic approach that we've got to take. It's leveraging partnerships. It's addressing both the street level side and the supplies that are coming in so that we can be impactful on that.
So to actually echo off what Chief said, it is a partnership. So we have to all work together, and that's what we've been doing. One of the things that my lieutenant and the sheriff's office have been doing is making sure that we are actually focusing on the larger part of the issue. The cartels, the way the money is coming in, the way the drugs are coming in. You know, the low-level piece of the pie is the street dealers. Those are not the ones that I'm very, very interested in. I'm interested in making sure that we can get the ones that's bringing in through the ships, through the trailers that we have, that we've seen, that we know that the stuff is coming in. It's a money-making system. If we can't get to that part of it, then we'll never be able to break the rest of it down. So we just have to continue to work together as a team, task forces, organizations, and hopefully people will come and actually give us information that we need. We can't do it alone, so it's going to take all of us to get it done. And of course, we need money, you know, state money, federal money, to get things done, to put more people on the street or more officers out to get things done. Okay.
Thank you.
Thank you.
Are there other tools that law enforcement needs to battle this?
Well, I mean, everything that the chief and the sheriff has said, I mean, it's a tool. It has to be a holistic approach because there are so many levels to this opioid epidemic, from a diversion side, from a suburban side to an urban side, to the cartel, to the street level dealer, to the soccer mom, to the person that just had surgery, they get addicted. So when you talk about tools, there are so many tools that are out there, as you was talking about, coming in through the mail. That's a federal crime, so you have to have partnerships with the federal government, which all of us maintain those. You have to have a great relationship, but more importantly, you gotta have community involvement, community credibility, because the community has to have buy-in to what you're doing and what we're doing. They have to feel and have a stake at this. I hate to echo off what the AG said, but he said we're failing at this. And I applaud him for saying that and being transparent, but I also applaud him for what he said that I've known is that he is going after the distributors. He's going after the manufacturers. He's holding those accountability. And we have to hold everyone accountability, from the street dealer all the way to the manufacturer, all the way to across the waters and the borders. So I think, as we've all said many times, it has to be all hands on deck and a holistic approach.
Thank you.
There are truly bad, greedy people who are making unbelievable amounts of money, millions and millions of dollars, putting onto the street drugs that kill our people, our residents. And they're doing terrible things, and they need to be held accountable. We have tools like wiretaps, which we use, and we do this in partnership with the DEA. They're just really great partnerships, SBI, state level, DEA, local law enforcement. I convened a law enforcement task force on which Chief Schultz sits, and our challenge was, what gaps are there, what laws need to be changed, what other tools need to be brought to bear so that we can be very effective going after these criminals. And so one thing we learned was the law did not apply to all the forms of synthetic fentanyl that was killing our people. And so we went to the legislature and got that law changed so that now if somebody's bringing the fentanyl into this state, they're going to be found guilty, hopefully, and put in prison for a very long time. We heard from local law enforcement that there were drug rings of people getting pharmaceuticals but putting them into the street, making big money. And so we work with law enforcement in the legislature so that law enforcement have more tools to identify where those drug rings were and break them up. But we also have to understand there's a difference between people who are out there engaged in criminal behavior with greed in their heart to make money, indifferent to human life and suffering, versus somebody who is addicted and then falls into criminal behavior by the nature of their addiction. And law enforcement is recognizing that is reality as well. And so one thing we've done is had a conference among law enforcement across the state where they were sharing all the innovations that are going on. And there's great stuff going on across North Carolina where some law enforcement are saying, if you come into my police department with your drugs and your paraphernalia, I will not arrest you, I will dispose of that, and I will connect you to treatment. Others are empowering their police who are on the street and engage and find somebody in the community who's engaging in drug use that's illegal. They then have the discretion to identify, is this person somebody who wants to go into treatment? And they won't even make an arrest. They won't even start the process of connecting them with the criminal justice system. The theory is that to the extent we can move people struggling with addiction out of the criminal justice system and into the healthcare system where they can get treated and healthy, then we will actually have a reduction in crime. I was with Chase at UNC Greensboro with a very bright young man, early 20s, and he said, for 4 years of my life, it was hell. I got a rap sheet this long. I was engaged in all manner of property crimes because I had a $300 a day habit and I was going to get the money however it took to feed my addiction. He said, since I have been in recovery, I've not had a single impulse to commit a crime. We have to break that cycle of addiction that leads to criminal behavior, and law enforcement is increasingly recognizing that. But as the chief says, it's a very tough balancing act. We want to hold the truly bad guys accountable, and we want to help people with addiction get better, but sometimes
the line is fuzzy.
It isn't clear who's who.
Right, okay. All right, so at this point, we have talked about the problem, and we have talked about prevention, we've talked about treatment and recovery, and we've talked about enforcement. So we want to take the last few moments here to take any final questions from the audience, those who are here with us, those of you who are live on Facebook as well. Tahisha?
Yeah, so we have a couple of options here. Let's start with those who are incarcerated and who leave jail. They were on drugs before they got to jail. Are there any programs available or upcoming programs specifically for those who were incarcerated or recently released from jail, prison?
Sure. So here in Guilford County, most recently, we've been working with the sheriff's office. We've recently hired someone to go into the jails and do individual interviews with those that are on the detox protocol there, or have been identified as someone with a substance use disorder, working very closely with the Reentry Counsel as well on that, gaining access, and we'll begin hosting groups soon for those individuals. Just in a few, maybe a month or two, we've already connected a large number of people that were incarcerated to treatment, sometimes through custody release to go from jail to treatment. It's been very successful, and we're happy to be with those individuals and get them to a place where they should be.
And do you know of any programs for people who are struggling with mental illness? We talked about trauma, how that is sometimes a gateway into needing these prescription pills and heroin and things like that. Is there a hotline where someone can just talk and someone will listen? This person who wrote here, they said there's just a void missing, and many times they just want a friend to listen instead of wanting to prescribe a pill or a treatment. But sometimes going to family and friends is not always the way.
So there are a lot of different hotlines available for a lot of different things. And so I think, again, the More Powerful NC is a great place to start. Also SAMHSA, because SAMHSA both supports mental health and substance use disorders. Those are great websites to start at. There are also things like apps, Talkspace, some other options if you don't have maybe the ability to leave your home, or you don't want to leave your home, or whatever it might be. There are just more creative opportunities now for individuals. And so starting with that More Powerful NC and SAMHSA is a great place to find some resources.
All right, as we're looking through some of the other questions and stuff like that, I know she's got like lots of index cards there, and we're glad that a lot of people participated. Many of you probably asking a lot of the same types of questions as we have been going through this last hour and a half or so. It just struck me about how all of you had talked about prevention, getting it in front of kids sooner, and also recognizing that kids have gone through something traumatic and would possibly abuse later on. So that to me sounds like schools interaction for sure. And I think we've all, known about guidance counselors in the schools and how there's not as many there. Is this what we're talking about? I know you were talking about prevention and getting in with the kids earlier. It's not just warning them, but it's also identifying.
And
True.
drug testing our children.
So when I spoke of getting into the school system at an early age, I was referencing getting into the middle school and elementary school. Some years ago, there used to be a program called the DARE program. It has faded away. But I'm talking about getting into the elementary schools and educating our kids on the effects of drugs, educating them on the cause of drugs, educating them on how it affects their lives and how it will affect their lives. We've got to have some mentoring in our elementary levels. We've got to have real conversations at our middle school levels, because if you go across any county in this state, you'll find that there is drug use in our middle schools, whether it's from the medicine cabinet, whether it's from another kid urging them to try something. So we have to definitely look at that from that approach as early education of this epidemic that we're dealing with.
Gotcha.
This is where we need to have a public health mentality and recognize that societal behavior can be changed. Exactly. We have over time, until Jewel hit our high schools, seen a dramatic reduction in teen smoking. It wasn't an accident. We've seen a dramatic reduction in teen pregnancy. We've seen a reduction in teen drinking. We've seen an increase in teen seatbelt use. The idea that a kid would get into a car today and not put on the seatbelt, it would be crazy to them. These things didn't just happen. It was because we as adults made a decision, these are behaviors we wanted to change, and we developed evidence-based strategies, communicated them to young people in a sustained way and with sufficient resources to make an impact. So we can change young people's behavior. We just have to put the materials in front of them. Right now, the level of misconception about young people and drugs is just mind-boggling. The majority of kids think that taking prescription drugs of a friend of theirs is safe because it was approved by the government and a doctor prescribed it.
Well, just adults think that too, that they can take somebody else's prescription, that it's okay.
We have to be intentional about We must be intentional about this. It can't be something that we do occasionally. When you talked about the numbers declining on smoking and alcohol use, seatbelts amongst our teens, we were intentional about that message. We were intentional about bringing all of our resources to bear for the same common denominator. And that's the same way we gotta approach this opioid epidemic, because I've said it twice tonight, I know. We talk about this drug war. Anytime we are losing the numbers that we're losing per year, that is horrible. We are better than this as a country. We are better than this. And it has to be public enemy number one. And we have to change how we look at the addiction, because how we look at the addiction determines how we apply our resources. How I look at you, how I see you, will determine how I treat you and what I'll do for you. So we've got to look at those that suffer from addiction as human beings that need help and need our support. And we've got to change this atmosphere.
Gotcha. Tahisha, did you have a few more questions?
Something that could spur some discussion here. One person wrote, I have a CDL license and I'm required every 2 years to be tested for drugs. Are there random drug tests? And there are random drug tests for CDL drivers. Why can't we bring this down to regular drivers?
And drug test everybody is what they're saying.
A random drug test for drivers and proceed from there.
Bringing up drug tests, and I was trying to talk to that. My daughter, when she was addicted, she said that when she was being randomly drug tested by myself and by the judge, she knew she had to stay clean and did. She said it was when I congratulated her, patted her on the back, or the judge gave her a certificate telling her, good for you, you've completed a year, you're good and clean, and we love you, and go have a great life. She fell off that cliff because there was no safety net. And one of the things I would like to see is us putting drug tests into the hands of parents, like at PTA meetings. Put the drug test in the hand of parents and put it beside the toothbrush and say, that's not because I don't trust you, that's because I love you. And I will randomly test you just so that you never know when I'm going to test you. And if I may, part of that is that Toria knew that once she tried drugs, it was like a riptide. It sucked her in. She didn't realize. She thought she was invincible. Like you said, with the drugs being prescribed by a doctor, we don't think about the dangers. And this was in Toria's journal, and it's pretty powerful. She called it the voice of addiction. Well, it's nice to finally meet you. I've been waiting for your call. I've noticed you've been crying, and I've watched you pace the halls. Whatever's been hurting you, I can make it disappear. You know you have nothing to lose, nothing to live for, nothing to fear. Thank you for your invention. I'll be sure not to leave your side. We'll become very fast acquainted. My naive child, there's no use trying to hide. I should probably introduce myself. I am your very own addiction, but you cannot be angry with me. I am your own self-conviction. I bet you feel rather stupid, falling right into my lap. I'm a master at manipulation, and you will never escape my trap. And that's what the kids need to hear. They need to know it's a trap, and they won't escape it.
To answer your question, who will pay for that? And that's the question that you're going to get every program that you talk about. Who will fund it? Who will pay for it? So you think about the number of drivers that we have in North Carolina. Who will pay for that? You think about the treatment, as the AG and all of us have said, is that there are not enough beds. It comes back to dollars and cents. It comes back to how we see the addiction. What are we willing to do, and how are we willing to fund it?
And Dr. Schilling, you were talking about how it costs a whole lot less to treat than to incarcerate, to do X, to do Y, to do Z. But I think people as a whole, right, they start to just see it as, well, it's just too much, right? It's just too hard. It's just too complicated. But that's what this whole panel is about, to make it not that hard, not that complicated. So I guess the thought is, what is our next action step? Any of us who are watching, any of us who are here, is it calling our lawmakers, city, county, state? What is it? Because what can we do?
I think the action step, as some of us have tried to start in our own counties and communities that we come from, is that you got to bring the community together. You got to bring mental health. You got to bring social service. You got to bring the Teachers Association. You got to bring everybody in that community, because everybody in that community, if not, will be affected by it, whether it's their house being broken in, a car. So the next step is we've got to start to develop what I call action groups in our community. How do we help people? You know, in certain cities, if someone needs help, they go get the shot in the morning, then they got to go clean across town. They might not have the resource to get there. We've got to bring resources to bear. We've got to bring a holistic approach. It cannot be just fragmented as we are approaching it. You alluded to it's cheaper to incarcerate somebody, but the facts of the matter, the people that we incarcerate for drugs are the people that don't have the money to make bail, the people that don't have the money, access to the system. So, I mean, we got to look at this from a realistic approach without shaded glasses. It has to be from a realistic approach. That's the only thing. And we've got to understand how we got here and how we're going to get our way out of here. It can't be political. It can't be racial. It has to come back to the bottom line, life and death. And we're all under the same umbrella trying to live.
There's truly something that every single person watching this who cares about it can do. Not everybody does exactly the same thing, but there's something that every single person can do. And if you want a dozen ideas, you just go to the website, morepowerfulnc.org, and click Take Action. There's a pledge you can take, and it'll give you 10 different ideas. Go check your medicine cabinet to see if there are any pills. Get them out of your home. If you need those pills, lock them up. If you have children, talk to your children about the risks of taking other people's prescription drugs. If you're on the PTA, get your school to put a curriculum, and there's curriculum on the webpage that schools can integrate into their health programs. If you're in the Chamber of Commerce, there are things you can do. If you're a business owner, there are things you can do. There are so many things that each person watching this can do. You just have to know what it is and then execute. So we want people to go to that website and take a pledge. And then one thing that folks can do at this moment is, if you agree that we need more treatment in North Carolina and that we need more healthcare options available to people sick with addiction, then we need more insurance. And that means Medicaid expansion. That is the issue that's holding up the budget. And if you think we need to have Medicaid expansion, please call your state representative, call your state senator, and tell them to just say yes. Easiest thing they could do.
All right, so we're going to start wrapping up our town hall. And so what I want to do is to get some parting thoughts from each one of our panelists. And what I want you to do is I want you to share one thing or one area that you're hopeful that more can be done to improve the opioid crisis. So one thing that you're hopeful that can be done to improve the opioid crisis. And so, Chase, let's start with you.
Sure. I think what gives me the most hope is that all of these people are sitting in here today talking about this, and that there are people online watching this that care about this, and people are starting to have the conversation. I think the brave souls that fought the AIDS epidemic had it right when they said silence equals death. And we've been silent about this for a very long time, and it's literally been killing us. So I'm encouraged just to see people have this conversation. I'm encouraged to see law enforcement at the table saying we can't arrest our way out of this. I'm encouraged by a lot of things that I see, and I hope that we continue to have these dialogues with compassion and kindness and loving in mind, and that we start to truly see people for what they are, as people, no different than you or I. I mean, I'm one of those people. We're everywhere. There's people in recovery in your life, whether you know it or not. People that use drugs and people in recovery are your doctors, we're your lawyers, we're your law enforcement, we're your EMS, we're your customer service representatives, we're everywhere. We're just not supposed to talk about it. So I'm encouraged that more people are starting to stand up and talk about their experience, and they're being listened to and they're being welcomed by folks like yourselves that attend meetings like these. So I hope that we continue to have conversations about this.
The most important things, I believe, is reducing stigma. Putting a face on this epidemic is something I'm trying hard to do. You can submit your pictures of loved ones that you've lost to tealdrops.org, that's our website. We are putting faces with the numbers. It's so diverse, rich, poor, black, white, every country. It does not discriminate, and showing the faces and the hearts and the stories that it's you and me, and putting that human element. And the second part to that is drug test your kids. Very young, start young. The breakdown of the family and the hurt from divorces, we don't realize how bad our kids are affected by violence in the home and hurts in the home and lack of God in the home, lack of prayer. We have to get back to God and family as being the core. If the family unit's together, the child has so many more chances. That doesn't mean you're going to be home free. I know a lot of couples that have lost children. But having two parents working together for their children from a very young age is very impactful.
I have the exact same answer as Susan and Chase, which is the ability for more people to talk honestly and openly about their addiction, about their chronic illness. And it's only when people are willing to be frank with themselves about their substance use disorder, their mental health challenges, that it's only then that they will be in an emotional place where they can then get the help that they need to get well. So I think that's something that's very encouraging. I think from just because I'm the Attorney General and I see a lot of the world through a law enforcement lens, another thing I'm encouraged about is these law enforcement leaders here, the two sheriffs and the chief. Law enforcement has a job to do to keep our communities safe and hold bad guys accountable, but we also recognize that the way we've been doing it hadn't solved the problem. And so there's a willingness to try new things, and that's encouraging to me as well.
That's a hard question to answer, and I think everyone so far has done a really nice job. I think the one thing I would echo related is to be willing to have a conversation with someone when you notice something is not right. You know, to be willing to be the person who says, hey, something seems not right here, can we talk? Or I'm here for you, or whatever that might be. Because that starts breaking down the stigma. And that's really a very small thing that you can do with your coworker or your next door neighbor or whatever it might be, the Uber driver that's driving you to the restaurant. You know, these are things that you can do that don't take a huge amount of time and effort, but do start to connect us as human beings again. And then I think what is so phenomenal about North Carolina right now is there are so many projects aiming to help this situation. And so if you wanted to take a next step to get involved, so Susan mentioned very early that we have a master's program at Wake Forest where we train licensed clinical addiction specialists, and that program's at our hospital. Learn to be a licensed clinical addiction specialist. Or it might be, come to a community event that the sheriff's office is putting on and engage with those in that way. Anyway, I'm an introvert, so this is hard for me. And, that might not be the way, but the way you might do it could be having that conversation with that person who might be struggling with something and asking them what's happening. What's happening here? I want to be here for you.
I think that the transformation that we're looking for is in our transparency. And I say that having experienced it close and near and dear to my heart. I never discussed how my wife passed when she died. I never would even talk about it. But life made me talk about it, and I became transparent. I realized that being transparent about it, I was able to help others that were dealing with the same things. I was able to tell my story. So I think that first we must be transparent and realize that there is a problem. And we're fighting an unconventional epidemic with conventional ways, and it's not working. We're failing. We've got to be transparent about that. And we've got to be transparent, realizing that it's affecting all of us in some kind of way. And the last thing is that we must have hope, because our hope will determine how we see this epidemic. We must realize that we can do this. We can win. We just have to change and be intentional, as we did with other issues that we had, societal issues, whether it was tobacco or seat belts or things. And once again, I applaud you for grabbing the bull by the horns and doing this. This should be a conversation taking place every week or every month throughout this state and throughout this country. that's where the change takes place, being intentional.
Well, I love what you said about intentional, and I think about some of the resources that you have on your website. So what I want to challenge people to do is, okay, maybe you're watching the Facebook Live right now, so why don't you, like your local police department, sheriff's department, right? Because they're going to post those community events that you were talking about of we have to get the community together to buy in, to do a lot of some of these events so that we can kind of come together. You're going to know what your county sheriff's department or your police department is doing, and that way, that is one way for you to take action. AG Josh Stein, will you tell me one more time so that everybody can get it again of where they look for that resource guide and those 12 or 13 different things that they can do intentionally?
Sure. morepowerfulnc.org, take action, and then it'll say take a pledge. And if you look there, they'll give you 10 different ideas. You just click at the one that makes sense for you. Because as Dr. Schilling said, some people want to get out there and talk. Other people want to have to a group. Other people want to have one-on-one conversations. There's 100 different ways you can make a difference in other people's lives.
Right, okay. We want to thank you, all of you who came tonight for that entire town hall meeting, and you sat here live in the audience, and you brought your questions, and you brought your comments, and you listened to the panelists and things. We want to thank all of you who were watching live on Facebook or on YouTube or on WFMYnews2.com. We want to continue this conversation. We can't solve all of the issues, right, in one town hall meeting, but we can share ideas and we can kind of figure out where we need to start and stop and where we need to go next. And so we hope that you'll continue the conversation with us. And we just thank you. We thank you all for being here. We thank you all for being here.